Greetings and a warm welcome to everyone. I am Asya, the assigned moderator from DentalNet. It is my proud privilege to extend a heartfelt welcome to all the delegates joining us from across the country. We are indeed fortunate to have the valuable support of esteemed doctors, and I express my gratitude to each one of you for dedicating your time to be with us today. Allow me a moment to introduce DentalNet, which is a dedicated all in one medical content platform designed exclusively for dental professionals. Our mission is to empower dentists, hygienists, dental specialists, and students with cutting edge evidence based knowledge to elevate patient care and foster ongoing professional growth. At DentalNet, we bring together a nationwide network of dental experts to share their knowledge, clinical experience, and practical wisdom. DentalNet is honored to be associated as the digital partner for this esteemed event organized by the Indian Dental Association Hisar. We are truly delighted to collaborate with such a respected professional body and to contribute to the success of this academic initiative. The topic for today's session is the Adhesive Blueprint, Mastering Bonding Protocols and Cement Selection for Every Restoration. It is my great privilege and honor to extend a warm welcome and introduce our esteemed speaker and panelist for today's session. So, we are deeply honored to have with us our keynote speaker, Dr. Deepika Dodeja ma'am, who is a specialist in maxillofacial prosthodontics and aesthetic dentistry. She holds the esteemed qualifications of MDS in maxillofacial prosthodontics, reflecting her advanced training in restoring oral function and facial aesthetics. Based in Thane, Maharashtra, Dr. Dudeja is known for her expertise in maxillofacial rehabilitation, smile designing, and comprehensive prosthodontic care, helping patients regain both confidence and quality of life. She is also a member of the Indian Prosthodontic Society, demonstrating her commitment to continuous learning and professional excellence. With her precision, artistic approach, and patient centric care, Dr. Dudeja has earned recognition in the field of aesthetic and restorative dentistry. We are extremely delighted to have her with us today. We are equally privileged to be joined by our distinguished panelist, Dr. Bhuvan Nagpal sir, a renowned expert with an exceptional and diverse academic background. He holds numerous qualifications including BDS, MDS, PGD, MSc, MBA, PGD, MLS, LLB, CCOMS, and a PhD, reflecting his multidisciplinary expertise and commitment to continuous learning. Dr. Nagpal serves as the Joint Secretary of the IA Path branch and is a senior oral pathologist and clinical biochemist. He is also the founder president of POPMA Hisar. With his vast experience spanning pathology, biochemistry, and healthcare leadership, Dr. Nagpal brings a comprehensive and insightful perspective to today's discussion. His contributions to research, education, and professional development have been widely recognized and appreciated. So now I would like to hand over the session to you, sir. You may proceed. Thank you.
Yes, sir. Yeah, thank you, Aisa, and very good afternoon to one and all. Respected speaker, esteemed colleagues, and dear participants. It is with great pleasure that we warmly welcome you all to today's academic session under the IDA Hisar webinar series titled The Adhesive Blueprint, Mastering Bonding Protocols and Cement Selection for Every Restoration. IDA Hisar branch has always remained committed to promoting continuous professional development and evidence-based clinical practice. In today's rapidly evolving dental landscape, a strong understanding of adhesive protocols and material selection is not just desirable, but essential for achieving predictable long-term restorative success. We are privileged to have with us Dr. Deepika Dudeja ma'am, an eminent expert in prosthodontics and aesthetic dentistry, whose clinical insights and academic excellence will undoubtedly enrich our understanding of this critical subject. Her expertise and perspective will provide valuable practical guidance applicable to every dental practice. We also acknowledge the efforts of our organizing and coordinating team, including our dedicated office bearers and academic collaborators, whose commitment has made this session possible. We are confident that today's webinar will be highly informative, clinically relevant, and intellectually stimulating. We encourage all participants to actively engage, interact, and make the most of this learning opportunity. Once again, we welcome you all and wish you a productive and enriching session. Now, over to you, Deepika ma'am.
Yes, sir. First of all, a very good afternoon to everyone who has joined on this Sunday afternoon with us. Also, I would like to thank IDA Hisar branch and especially Dr. Nagpal for giving me this opportunity. So I hope you all will enjoy the session and it will be helpful for everyone. So without much ado, I would like to start with the session. Should I start with the screen share?
Yes, ma'am, you will be able to do it. Please
Okay.
check once.
Yeah, just a second. I think I've lost it again. One second, I'm sorry for the delay. Not able to share it. Should I close the PowerPoint? Because, yeah, okay. Is it visible?
Yes, ma'am, it is visible. You can just
Oh,
make it in the slideshow mode once.
yes.
Yeah, ma'am, it's visible.
Okay. So I told the topic for today is adhesive blueprint. Times because we are moving from full crown dentistry to more minimally invasive restorations, which don't rely on the friction fit, but rather solely rely on the adhesion to keep the restoration in place. So I would like to start the presentation. So, yeah, so as I said, the reason why we are here is because we are moving from the old school friction fit dentistry, which would rely on parallel walls and adequate taper to retain a restoration. We are so modern nowadays we rely more on the chemical bonding than the friction fit. So how does a chemical bonding work? It just doesn't place a restoration. We don't just place a restoration, we create a monoblock effect. What is a monoblock effect? It is something in which the cement or the adhesive becomes a part of the tooth as well as the restoration. Okay, so as you all can see in the picture, we are moving from the full crowns to the minimally invasive. I think I'll move this to the minimally invasive overlay preps. So the leverage of the chemistry will help us retain these restorations, which will be strong enough as well as aesthetic. So before we start with the actual adhesion, I would like you all to understand what does a bonding interface constitute of. So we should understand what are we bonding to and what are we bonding with. We are essentially bonding to the tooth on one side and to the ceramic on the other side with the help of an adhesive or a cement in between. So as you all can see in the image, on the left, the first interface is between the tooth and the adhesive, and the second interface is between the ceramic and the adhesive. So this adhesive or the luting cement is what uh, it acts as two different molecule on both the sides to marry completely two different substrates, which is the tooth and the ceramic. To bond to the tooth, it has to act as an hydrophilic molecule, and to bond to the ceramic, it has to act as a hydrophobic molecule. So this is what is a connecting bridge between the two. So this entire is the adhesive triad. So let's start by understanding each interface individually. First, let's try to understand the substrate, which is a tooth. Then we move on to the adhesive. Then the third substrate, which is your ceramic. Okay. So the tooth essentially is enamel and dentine. Okay. Enamel, as we all know, is a crystalline structure with high mineral content, hydroxyapatite content. In the image, you all can see the prismatic shape of the enamel. The enamel has high surface energy, which means that it is easy for the bonding agent to spread over the enamel. It has more wettability. Okay. So how do we bond to enamel? It is very easy after the introduction of acid etching by Dr. Bunoker, in which a 37% phosphoric acid is used to etch the enamel. Once the acid etching has taken place for around 15 to 20 seconds, which is a recommended time, the hydroxyapatite crystals are dissolved in enamel, leading to a micromechanical structure which we can bond to. Okay, you all can, as in the image, you all can see once the hydroxyapatite crystals are dissolved, it creates surface irregularities into which the bonding agent can penetrate and form micro tags. Okay, I hope I'm clear till now. So bonding to enamel is the most predictable and the easiest form of bonding, which is micromechanical. The challenging part is bonding to the dentine, which is an organic complex, as it has more organic and water content and less of mineralized content. Okay. Also, the dentine is different as we move from the superficial dentine to the deeper dentine. So it's a very dynamic environment which we need to bond to. Also, it has other structures like dentinal tubules and odontoblastic processes. Also, there is pulpal pressure from inside, which leads to the high moisture content into the dentine. So it is more of an hydrophilic environment. So we need to know how to handle this moisture effectively in order to get the maximum out of it. Okay, so now how do we bond to this dentine structure? As I mentioned, what there are many challenges that we come across while bonding to dentine. One of which is the moisture which is present because of the dentinal tubules. Second is the hydroxyapatite crystals, which are more randomly arranged in dentine as compared to enamel. Third is there is always a smear layer present after the preparation of dentine. So all these challenges we need to take over in order to effectively bond on the dentine. As you all can see in the image on the left, in the superficial dentine, the diameter of the tubules is less. And as we move towards the pulp, the diameter of the tubules increases. So essentially, there is more amount of intertubular dentine. Intertubular dentine is the dentine which is present in between the tubules, which is more important than the peritubular dentine present around the tubule. Okay, so superficial dentine has good bond strength, but as we move deeper, because of larger tubules and less intertubular dentine, the bonding, the strength of bond is not as much as we would require. So to overcome this, Dr. Aleman, as most of you all must be knowing, is given the biomimetic principles. According to his theory, we should we should allow like some time for the bond on the dentine to mature, which is called as decoupling with time. So before bonding to the enamel or connecting the dentine bond with the enamel bond, we should wait for around 5 minutes for the dentine bond to mature. Okay, so the image on the right shows hierarchy of bondability. What does this mean? Now, the bond on the enamel is the strongest, as we all know. As we go deeper, the bond strength decreases. So this hierarchy, we need to make use of this hierarchy. How do we make use of it? When we bond to the dentine, first is we do immediate dentine sealing. What is immediate dentine sealing? As soon as we have prepared the dentine, the freshly cut dentine is layered with dentine bonding agent, which are usually filled resins. Okay, and we leave it for around 5 minutes, or as long as we can, even if it is a day or two, the more the better. Okay, so once the bond to the dentine has matured and then we connect it to the bond of the enamel, it doesn't, the polymerization shrinkage will be much less, and it will lead to less post-operative complications. Okay, I'll not dwell more into the IDS part, but essentially, IDS is just immediately covering the prepared dentine surface with a filled resin and leaving it for at least 5 minutes to over 48 hours so that the dentine bond matures, and then we can connect it to the enamel bond. So previously, it was believed that the polymerization happens towards the light source, which is not true. The polymerization happens, the pull is towards the highest bond strength, which is the enamel. So when we separate the two, that polymerization shrinkage automatically is reduced. So then, okay, what is a smear layer exactly? Whenever a tooth is prepared, the organic or the residual debris which forms on the surface, it is called as a smear layer. It fills the orifices of the dentinal tubules, forming smear plugs. Okay, it is a residue which fills the dentinal tubules, forming smear plugs. The hybrid layer. Okay, the important part of the entire adhesion triad. How it is the most important? Because this is what will bond the tooth to your restoration. Okay, what is an hybrid layer? Once the dentine is edged, in the phosphoric acid, it demineralizes the 3 to 5 micron of dentine surface, exposing the collagen tubule, exposing the collagen mesh in the intertubular and the peritubular dentine, which provides an ideal surface for micromechanical bonding. Now, what does this mean? After 15 to 20 seconds of dentine etching, which is recommended, the action demineralizes the superficial 3 to 5 microns of dentine. So your smear plugs are removed and your dentinal tubules and the collagen meshwork present in between the tubules is exposed. Okay. This exposed collagen, when layered with adhesive, the adhesive penetrates into the collagen and the dentinal tubules to form the hybrid layer in the form of micro tags and macro tags. Okay, after you have demineralized the dentine using the etchant, you apply a layer of adhesive which penetrates into this collagen meshwork and the dentinal tubules to form resin tags, which is the hybrid layer. The effective penetration of the adhesive into the collagen fibers results into the formation of the hybrid layer. Okay, so this is the weakest part, also the most important part of the adhesive triad. If we tend to over etch the dentine, there will be more thickness. If we over etch the dentine, we will increase the thickness of the hybrid layer. How? Once the if you have over etched, the demineralization is quite deeper, but the bonding agent may or may not penetrate to the entire thickness. So this gap which is created between the residual demineralized dentine and the penetrated bonding layer is what will act as a weak link. So it is not about the thickness of the hybrid layer, it is mainly about the quality of the hybrid layer. The hybrid layer should be formed when the entire collagen is enclosed in the resin. Okay. Okay. So once you have etched the dentine and you rinse it and then you dry it. So now this is the most important step that we should be looking at. Over drying the dentine is what will create all the complications like post-operative sensitivity, your micro leakage, secondary caries, etc. How? When you over dry the dentine, the collagen fibers which are exposed will collapse. This collapse of collagen fibers will not let the adhesive it in completely and form a hybrid layer. Okay, so what should be the state of the dentine in terms of moisture? It should be moist or glistening. That is, it should not have any water droplets, but it should have a glistening appearance. Say now, inadvertently, if we have over dried the dentine, we can use chlorhexidine, which also acts as an MMP inhibitor, or we can use the primer of the adhesive system to re-wet it. Okay. Also, the other way, if you have left more moisture or you have not effectively dried the dentine, then the primer or the adhesive will get diluted with the water and still you will not receive a good bond strength. Okay. So to combat this problem of over drying or less drying of the dentine, there was an invention for self-etch systems. Okay, we'll be speaking more in detail about the different types of bonding systems as we go ahead. Till now, we have learnt about one part of the adhesive triad, which is a tooth substrate, enamel and the dentine. How we bond to enamel using 37% phosphoric acid, which creates micromechanical retention with the help of micro tags. Also, how do we bond to dentine? We bond to dentine after we can either etch it and apply a bonding agent, which will help us form the hybrid layer. Okay, now moving on to the second link, which is the bonding systems or the adhesive systems. Now, the bonding system essentially has three components. One is the etch, the second is the primer, and third is the bond. Okay, so the fourth generation of bonding agents, it has all the three steps. So it is called as a three-step routine. First step is your etchant, 37% phosphoric acid. Second is your primer, which is hydrophilic. Third is your adhesive. Then, to make it more simpler, a fifth generation of bonding agents was introduced, in which you have an etchant, but the primer and adhesive are mixed into a single bottle. Okay, to make it simpler. But there were certain drawbacks of this system. So the sixth generation, because as I said, there is always a risk of over etching with the help of when you use when you use a phosphoric acid. Also, you have to be very careful to not overly dry the dentine after etching it. So to reduce these complications, a sixth generation of bonding agents was introduced, in which the etchant and the primer were put into a single bottle. So we are not etching it, rather we are using a milder etch with the primer to etch the dentine. Also, these generation of bonding agent are more tolerant to moisture, because we are not dependent on the state of the dentine after etching, right? Then comes your seventh generation and the eighth generation, in which everything is put into a single bottle, your etchant, your primer, your adhesive, everything. So seventh generation is not widely used you're using it. But the universal bonds, which are the eighth generation bonds, are the ones that are gaining more popularity these days because they can be used in multiple ways. It can be used as a self, as for with your total edge technique also. It can be used with your selective edge technique also, or they can be used as a self etching primer and bond as well. So I think as we move ahead, you'll get more clarity about the bonding systems. So acid etching, we all know it's 37% phosphoric acid. Second is your what are the primers? Primers are hydrophilic. They are hydrophilic. Why they are hydrophilic? Because they have to wet the dentine, which has which has less surface energy, and it doesn't let the adhesive penetrate easily. So to increase the surface energy of the dentine, we use something called as a primer. They are hydrophilic, low viscosity resins, and they have a bifunctional monomer. Bifunctional as in it has on one side it will act as a hydrophilic that will increase the wettability of the dentine, and on the other side it will act as a hydrophobic, which will which will help the adhesive to bond with the tooth. Okay, so these primers are essentially dissolved in solvents like acetone or ethanol water. Okay, so how do they act? Once you have you know once we have acid etched the dentine, the collagen fibrils are exposed, and they are since they lack the hydroxyapatite. Okay, so they lack the hydroxyapatite, so they are fragile and sponge-like. So they need the primer to prepare it for receiving the bonding agent. After you have applied the primer of, usually we apply multiple coats of primers because the solvent evaporates quickly. In the image, you all can see the micro tags that are formed. First, you apply the primer, then on top of it, you apply the bond, and then you apply the resin cement or your composite. Okay. Now these bonding agents, essentially they require different adhesive strategies. As I said, it could be either total etch, self etch, or multi-mode. Total edge, usually in with total edge, as the name suggests, you entirely etch the dentine and the enamel, and then you use a primer which is hydrophilic, and you use a separate adhesive which is hydrophobic. Why? Because it has to bond to the cement, which is also hydrophobic. Like no it can't the cement generally doesn't tolerate water molecules or any moisture. So the adhesive has to be hydrophobic, and the primer has to be hydrophilic because it has to wet the tooth. So the fourth generation of bonding agents, as you can see in this image, this is the gold standard for bonding because it achieves the maximum bond strength to the dentine, because as the primer effectively wets the dentine, and the adhesive acts as a separate hydrophobic layer to bond to the cement or the tooth. But this is too very technique sensitive, as relying more on the operator's skill, or because if you over dye the dentine, the collagen fibers may collapse and there'll be less bond strength. Also, if you don't dry the dentine effectively, still there will be compromise on the bond strength. So this is a very technique sensitive but a gold standard. So the fifth generation is etch and two-step. Okay, in this generation you etch the dentine and the enamel, and you apply a adhesive which is a mix of hydrophilic and hydrophobic. Okay, so once you have mixed the two, the The dentine, the state of the dentine is again very important, because if it is too wet, the hydrophobic part of the adhesive may or may not act effectively. Okay. The self etch, as the name suggests, we are not using any etchant. So there is no rinsing and no over drying the dentine. We are using an primer which is acid plus primer. So these are mild as compared to the orthophosphoric acid. So, and they don't completely remove the smear layer. They partially remove the smear layer and incorporate the rest of the smear layer in the adhesive. So as because the smear layer is left almost intact, there is less post-operative sensitivity with these type of bonding agents. So we need to see the clinic where which type of bonding strategy should be used. If we are working on a deeper dentine where or the patient is complaining of post-operative sensitivity or the patient is highly sensitive, then sixth generation of bonding agents which comprise of self-etch, primer and adhesive is what we should be looking at. In routine dentistry, these are the sixth and the eighth generation bonding agents are the ones that we should be routinely using. Okay. So the self-etch is also the seventh generation is also a self-etch bonding system in which the etchant, primer and the adhesive are all packed into one bottle. Okay. I usually don't prefer this type of bonding agent. Then comes your eighth generation. Why an eighth generation? Because eighth generation can be, these are called as universal bonds. They are called as universal bonds. Why? Because they contain MDP. Now, what does an MDP monomer do? Instead of relying on the resin tags, this the phosphate part of the MDP molecule, it binds to the calcium from the hydroxyapatite. So this salt that is formed by with the calcium of the hydroxyapatite is relatively less water soluble. Also, they can bond to various other substrates like zirconia and alumina. Second reason why they are a workhorse of your routine dental practice is they can be used in different modes. You can either use it with total etch. If you have etched the enamel and the dentine, you can just paint on the adhesive and it will act as a total etch. If you want to use it as a selective etch, you can etch the enamel and to etch the dentine. It will act as a self etch. To etch the dentine, we need to scrub the adhesive into the dentine for 30 seconds and air dry it so that the dentine is effectively etched. Also, they can be used entirely as self-etch. So there are multiple ways in which you can use the universal bonding agents. So two bonding agents that you all should have in your clinic are your sixth generation, which is the primer and adhesive, self-etch primer and adhesive, and your universal bonding agents. So this is a cheat sheet where you can see which type of bonding agent you should be using in which clinical scenario. Say a fourth generation bonding agent is the gold standard. Why it is a gold standard? Because it helps you achieve the maximum bond strength to the deep dentine. So in areas where you are sure about your isolation, but but lot of dentine is exposed, this is the generation that you should be going for. The classic example is OptiBond FL, which I'm sure everybody's heard of. Then comes your fifth generation. Now, fifth generation of bonding agents, as I said, it is a two-step. You are etching the enamel and you are uh, the dentine is primed with the primer and adhesive together. So this type of bonding agent is generally used where you have more of enamel content, like when your preparations are entirely enamel, like in cases of veneers. Okay. Then comes your sixth generation bonding agent. As I said, they are more tolerant because the self-etch primer, it is a milder form and it doesn't remove the smear layer completely. So the post-operative sensitivity greatly reduces. So this type of bonding agent, you should be using it either for your immediate dentine sealing and for your cases which are placed into deep dentine. Then comes your seventh generation. You can use this for your basic fillings and in pediatric cases. The eighth generation bonding agent, these are again, you can use them for immediate dentine sealing. You can use them for your veneers. You can use them to bond your zirconias and alumina in place. Okay. So far we have learned about the two substrate. Then we have learned about the bonding agents. Now this is the third link, which is your resin cement. Okay. So resin cements are broadly classified into conventional resin cements and self-adhesive resin cements. The conventional resin cements are again classified into two, which are total etch and self-etch. Total etch means again you are etching the dentine and enamel both, and then you are applying the adhesive, and then you are applying the cement. Self-etch, as the name suggests, you are not using an etchant. You are relying on the self-etch primer and then the bond and the cement, so on and so forth. So the total etch cements are, they could be light cure, self cure, or dual cure. Mainly we in routine dental practice, we use the light cure cements and the dual cure cements. So the self-etch and self-adhesive resin cements are also popular because of their ease of use and less post-operative sensitivity. The self-etch, we look into each of these as we go ahead. So, okay, the etch and rinse, the total etch adhesive system. So as I said, it requires separate etching. They require separate application of the bonding resin and then your cement. Okay. So this could be self-cure, dual cure, or light cure. Where do we use, what are the indications for these type of cements? Uh, where you have more enamel present, that is in case of veneers, where you have highly calcified dentine, like in cases of sclerotic dentine in your class 5s, your non-carious lesions, and in fluorotic dentine. Also, when you are doing bonded restorations, like minimally invasive restorations like inlays and onlays, and you have margins in healthy enamel, these are the type of adhesive resins or adhesive cements that you should be going to. Okay. Second comes your, okay, now etch and rinse, as I said, it could be light cure, dual cure, or self cure. So first is light cure. Light cure, as a name suggests, it starts to polymerize as soon as it is cured with the curing light. So for the light to travel or reach the cement, it is necessary that the restoration is thin or transparent enough. So by logic, it says that it can be used for your veneer bonding of your veneer, or which are thick in microsection. Okay, so they have good bond strength to enamel. There is no mixing time involved. Also, you have ease of luting or bonding the restoration in place because they don't cure unless exposed to the curing light. So for your veneer cases or multiple, where you have to bond multiple restorations in place, but obviously the restoration has to be transparent or it has to let the light pass through it. So your common examples are Variolink and Relax Veneer from 3M. Are also Variolink and Variolink Aesthetic LC. Variolink Aesthetic LC. These are the common cements that you should be using for bonding your veneers in place. Okay, then come your dual cure cements. Dual cure, as the name suggests, they polymerize both ways, light with the help of a light also, as well as they self cure when they come in contact with the adhesive. Okay, so because they cure independently of the light source, they can be relied on for deep for cases where you have thicker restorations, or where you have opaque restorations. Thicker restorations as in when the ceramic thickness is more, or the ceramic itself is opaque, which doesn't let the light to pass through it. But since they are a part of the total edge system, you still require an acid etching and a primer and a dentine bonding agent, and then the cement. Okay, so you can, depending on the system that you are, or the brand that you select, accordingly, they have compatible bonding agents. We try and not mix the two unless you know the chemistry very well. You don't interchange the brands, like you don't use a separate bonding agent from another brand and the cement from another brand. We'll look into the reasons as we go ahead. So dual cure summary is excellent bond strength, even in deeper or shaded areas where the light cannot reach. Ideal for your restorations like zirconia, even metal or thicker in emax restorations. Okay. So if you expose the dual cure cement immediately to the light source, the complete polymerization, doesn't lead to the complete polymerization of the cement. So it is advisable that you expose it to the light source at least 5 to 10 minutes after the mixing, so that the complete polymerization takes place and you get a good bond strength. Okay. Now, after we have seen the total edge systems, now we are moving to the self edge systems. As the name suggests, self edge, as in we don't require a separate etchant to etch the enamel or dentine. Instead of the etchant composed of acidic monomers and phosphate esters, it is combined with the primer, and you get a self edge primer along with these type of cements. What self-etch primer, as I said, it has milder acid which will etch your dentine, and it will incorporate the smear layer into it. Okay. So usually the adhesive that you get with these type of agents, with these type of cements, are in two bottles, where you mix the bottle A with the components of the bottle B, and you apply it to the tooth structure. And the most important part here is you need to dry the adhesive completely to remove the residual acidic hydrogen. If not dried completely, the remaining hydrogen from the acid will remain in the set adhesive layer, which will be detrimental to your bond. So here we need to make sure that we are effectively drying the entire the adhesive till we see no ripples on the surface of the tooth. So uh, usually these primers contain 10 MDP. As I said, the MDP molecule, the phosphate group of the molecule, it forms a bond with the calcium from the hydroxyapatite. So it is a reliable bond. As I said, the advantage is that you are not removing the smear layer. So the post-operative sensitivity is highly reduced. So for your vital restorations, where you are deep into the dentine, but still the tooth is vital. These are the resin cements that you can opt for. I forgot to mention the examples for dual cure. Dual cure, as we had a Variolink aesthetic LC light cure, we have a Variolink aesthetic DC with its suitable primer. Also, Panavia V5 is also a popular example for dual cure cements. For your self cure cement, as I said, usually they have an adhesive which comes in two bottles. You mix the two. One example is Tokuyama STSM Universal, uh, and other one is Panavia 2F. Okay. What are the indications of these type of cements? When the retention is compromised, that is, you have shorter clinical crown height or over tapered crowns, which keep dislodging every now and then. These are the cements that you can go to. Inlays and onlays in deeper cavities, as I said, to prevent the post-operative sensitivity. Also, they are dual cure. Like once they come in dual cure, as in they have a touch cure mechanism. Once the bond or the primer comes in contact with the cement, they start setting. So unless you have the cement in contact with the bond, the cement doesn't set. So that is one more advantage of this type of cements. The last of the resin cements is self-adhesive. They are relatively easier to use, but of course, since they don't involve any primer or any etchant, the bond strength is relatively lesser than the other type of resin cements. The highest bond strength being with your light cure, then your dual cure, and then your self-etch adhesives. Last are your self-adhesive. Self-adhesive means you are not using any, everything is mixed into the cement. The cement itself acts as a etchant and a primer and a bond. So you are not applying any, you are directly loading the restoration with the cement and placing it in the patient's mouth. So where time is a constraint, or where you feel that you are not, the isolation is a huge problem, these are the cements that you can opt for. Also, they can be used for your routine crowns, which have adequate retention for like your zirconia, routine zirconia crowns, metal crowns, and your thick emax crowns. Okay, so this is again a cheat sheet to decide which type of, because there are so many cements available, which type of cement you should be using when and where. Okay, so first is depending on the retention that is required. Now retention, if the taper is adequate, okay, if we have good taper, we are just using a resin cement because of because of its other benefits, like low solubility in the oral environment and better retention. So in those cases, you can use a self-adhesive, because we are not mainly relying on the adhesive property of the cement. We have some retention from the tooth as well. But when the taper is compromised, you can move on to other cements like self-etch, like I said, the Tokuyama or the Panavia V5, where you have a bonding agent or an adhesive which will etch your tooth structure but not overly etch it, so you don't have any post-operative complications as well. Also, you have a good bond strength. Okay, same with the crown length. If you have good crown height, then which is more than 4 mm or 4 mm, then you can use your self-adhesive. If you have something crown height which is lesser than 4, then you can use either your dual cure or your self etch cements. Okay. If the number of remaining walls of the remaining walls of the tooth are two or more. If there are two or more, again, you can rely on your self-adhesive cements. The examples of self-adhesive are Relax U200. Okay, you can use those type of cements. And if you have more than two walls, less than two walls remaining, then you have to have a better cement like a total edge or a selective edge. If you have good enamel margins, then you can opt for a total edge. Otherwise, you can use a self-edge cement. Isolation, if it's in the difficult area like the posterior tooth, then you can use the self-etch or the self-etch is also a good option because the number of steps are reduced. You don't have to etch, rinse, dry, apply the primer adhesive. You can directly do a self-etch or a self-adhesive if you have relatively good retention into the present in your clinical scenario. If you are bonding your anterior teeth where isolation is pretty much simple, then total edge is the cement that you should go to in cases of your veneers. Okay, for your aesthetic demands, high demands, your light cure cements, the light cure cements from the total edge technique, they are available in various shades, and also as there is no tertiary amine present, so the shade remains stable over the period of time. They don't change the shade with time. So for your high aesthetic requirement areas, you should stick to a total edge cement. If you are bonding in the posterior segment of your mouth, you can use either your self-etch, dual cure cements or your self-adhesive cements. Material, when it comes to material strength, when you have weaker materials like feldspathic porcelain or you have thin emax veneers, they gain the strength once they are bonded to the tooth structure. So we need to stick to the gold standard, which is the total edge cement. If you have restorations which are strong enough, like zirconia, alumina, or thick emax restorations, you can use one of the total self adhesive or the self etch cements. Bonding substrate. So if you are bonding to enamel, as I said, you stick to total edge. If you are bonding mostly to the dentine, you don't require acid etching. So you stick to self-etch or self-adhesive. Hope this makes sense. Okay. So as I mentioned earlier, you should not be mixing the bonding agent from another brand with the cement from the other brand. Why? Because there is a incompatibility issue. What happens is when you use a dual cure, when you use the simplified adhesive systems, like simplified in the sense when everything is packed into a single bottle. Your hydrophobic, your hydrophilic, all the components are packed into a single bottle, and you have applied it in the deeper areas of your cavity preparation. And so this system will act as a hydrophilic layer, as in it will let the moisture remain on its surface, because they have that hydrophilic component to it. So that moisture will also lead to bonding issues. Also, the residual acidic monomers in the adhesive will combine with the tertiary amines in the composite, which can hinder polymerization. So as you all can see in the image, the free hydrogen molecule from the adhesive, from the bonding agent, it reacts with the amine, which is tertiary amine, which is present in the cement. Okay. So this reaction will also hinder the polymerization. Okay, so if you don't have bonding agents from the same brand, you either mix a dual cure component with the adhesive, so that dual cure, those usually the bonding agents require light to be cured. Unless they are dual cured, as in they cure independently of the light source, they will act as a hydrophilic layer, which will not then bond to the cement. So the cement remains in a gel form. So, but it's better to stick to the same family than mixing a dual cure component. Or these days you have dual cure adhesives as well. So you can use those. If you are using a fourth or a sixth generation, with the fourth or the sixth generation, you apply the primer, which is hydrophilic, and then you cover it with a hydrophobic layer of adhesive. So these are generally compatible with your dual cure cements. So because that hydrophobic adhesive will bond to the hydrophobic cement. Okay. So we have the last substrate, which is the resin. We have seen how to bond to the tooth substrate. We have seen the connecting link between the two. That is the dentine bonding agent, which is hydrophilic and hydrophobic to bond to your uh, composites and to your restorations. Then we saw which cement we should use. Now the last is your restoration, the surface of your restoration. Now the restorations are usually, we'll stick to two types of ceramics, mainly glass ceramics, which have a high glass content and a silica content, and your polycrystalline or oxide ceramics, which are zirconia. Your glass ceramics are feldspathic porcelain or your Emax lithium disilicate. Both these glass ceramics and particle filled glass ceramics, they have a high glass or a silica content which you can bond to. Okay, so first we'll look into how do we bond to a lithium disilicate or to a feldspathic ceramic. We'll take veneer as an example. Okay, the first step is hydrofluoric acid etching. 9% hydrofluoric acid is used for 20 seconds on Emax restorations to form, to dissolve the glass particles from the surface and create a micro retentive honeycomb surface. Okay, either you can use a 5% or a 9.5% for 20 seconds. Over etching again will lead to the weakening of the ceramic. Okay, so we need to strictly stick to 20 seconds of hydrofluoric acid etching. Okay, after the hydrofluoric acid etching is done, the second step is you wash the hydrofluoric acid for 1 minute, and then you apply 37% phosphoric acid. Why do we apply phosphoric acid again? To remove the residual ceramic salts that are left behind by the hydrofluoric etching. Okay, so first step is you use a 9.5% hydrofluoric acid on the ceramic for 20 seconds, wash it, dry it, apply 37% phosphoric acid for 60 seconds and wash it. The third step is silinization. Why silinization? Basically, it is done with the help of a silane coupling agent. You apply a silane coupling agent like Monobond, which is available from Ivoclar, or you get it with a Variolink kit, or you have silane coupling agent from Ultradent. So you apply a thin layer of silane on the entire surface of the ceramic, on the intaglio surface of the ceramic, and let it react for 60 seconds, and then you air dry it. You air dry the silane coupling agent. So how would you know whether you have effectively silinated the surface? One is appearance. It should have a frosty white and microscopically porous appearance, which shows that these are micro retentive areas which are formed for the bonding with your resin cement. Another way is when you put a drop of water over the silinated ceramic, it will form a droplet. It will not spread over because the silane makes the layer hydrophobic to bond to the hydrophobic part of the cement. Okay, so this completes your uh, preparation of the ceramic. Now we need to prepare the tooth to receive the bonding agent. Okay, so how do we prepare the tooth? It is again enamel etching for 30 seconds and dentine etching for 15 seconds with phosphoric acid. To the reason being the same, to create micromechanical retention and to form a hybrid layer. Okay, so depending on the bonding agent that you are using or the type of cement that you are using, light cure, dual cure, you do the tooth conditioning, and then final is your. Also, one more thing, after you have applied the bonding agent, you need to cure the bonding agent. Uh, Opposing to the popular belief that you need not cure the bonding agent and directly you can lute it with the or bond it with a ceramic. Reason being, as I said, if the two are not compatible, also most of the bonding agents are light cure unless you are using bonding agents which are self cure. Okay, like in cases of Tokuyama, the bonding agent is self-cure. So irrespective of the light, it will cure itself. So those, if you are using any other type of bonding agent which is not dual cure or self-cure, you need to cure the bonding agent. But the film thickness should be, it should be applied in very thin layer so it doesn't interfere with the seating of your veneer. Okay. The final is your cementation. You either use a dual cure or for your veneers, you usually use a light cure. You like a Variolink or Variolink LC, aesthetic LC. You can load the veneer with the cement and you seat it with passive pressure. Tack cure, you just cure the excess cement with the curing light for about 2 to 3 seconds so that the cement reaches a gel stage which is easily removed with the explorer. If you over cure it, then it is very difficult to remove the excess cement from your circular areas. So once you have done the tack cure and remove the excess cement, you can move on to the final polymerization after you have applied the KY jelly to prevent the oxygen inhibiting layer. Okay, so this is the sequence for your EMAX or your lithium disilicate glass ceramic. First is your hydrofluoric acid application for 20 seconds. Wash it. Then you put phosphoric acid to remove the residual salts for 60 seconds. Wash it, dry it. Then you apply a silane coupling agent. Let it react for 60 seconds. Then you air dry it. This completes your preparation for the ceramic. Then you move on to the tooth where you do your etching of the enamel and dentine 30 and 15 seconds respectively. You apply your selected bonding agent, light cure it for 10 seconds, not more. Light cure it, load the veneer with the cement and place it with a passive pressure. And you can tack cure it after that, remove the excess cement, and then the final polymerization, which is 40 seconds on every surface. Okay. Now we move on to zirconia. How do we bond to zirconia and why do we bond to zirconia? Okay, since zirconia is a high polycrystalline ceramic, it has no glass content. So because it has no glass content, the silane and your hydrofluoric acid will not help. Your routine uh, bonding procedure will not help. So we need something different for zirconia. So if your restoration, if your tooth doesn't have enough retention, we need to bond zirconia in place. Otherwise, if you have adequate retention, you can use your routine RMGI cements for placing the restorations. Also, the zirconias are usually, they are classified into three types. The 3Y, Y stands for yttria. Okay. So as the yttria content increases, the zirconia becomes more translucent, but less, it reduces the flexural strength of the restoration. So for your posterior high stress areas, you can stick to 3 tria zirconia. For your FPDs, you can stick to 4Y or 3Y zirconia. And for your anterior areas, for making aesthetic crowns, you have 5 yttrium multi-layer zirconias. Okay. So to bond your multi-layer zirconias in place, you so to you need a strong bond with the cement. So as I said, why can't we etch in silent? Because it is a polycrystalline ceramic and there's no glass component that you can etch or silica to bond to silane. Okay, the zirconia we use in dentistry is a oxide ceramic, that is zirconium oxide, and the oxide part is where all the bonding mechanism is going to take place. It is so basically the oxide part is a functional phosphate group that bonds to the zirconia. How do we bond to zirconia? It is a it is called as a APC technique, where A stands for air abrasion, P stands for primer, and C stands for the cement. Okay, since we are not etching the zirconia, so how do we create those micromechanical areas to bond to? So air particle abrasion with alumina, 50 micron alumina under low pressure. So is what is used to make those micro mechanical retention areas. Generally, if you have it in your clinic, good enough, but otherwise I get it air abraded from the laboratory when I receive the crown. Also, I would not recommend making inlays and onlays with zirconia, but still you can get an adequate bond strength if you are making inlays and onlays with zirconia. But this is mainly a protocol to bond crowns, non-retentive zirconia crowns in place. Okay. So the pressure of the air particle abrasion will be lesser for your more delicate transparent 5 tria zirconias. You can with your 3 tria you can stick to a normal that is 20 to 30 psi. Second step is your primer. Now there are special primers which contain MDP to bond to the zirconia. Why MDP is necessary to bond to the zirconia? As I said, the phosphate group is what is the phosphate group bonds to the oxide part of the zirconia. So the cements containing monomer 10 MDP exhibit particular affinity to metallic oxides such as zirconium dioxide, alumina, and metal. Okay, so the phosphate group of the MDP, it bonds to the oxide group of the zirconia. There are various primers available in the market. The 3M Scotch Bond Universal, it has an incorporated MDP, which is a universal bonding agent. Then you have Monobond Plus, which has both silane as well as MDP. So you can use it for both the surfaces. You can use it for your Emax as well as for your as a primer for your zirconia. Third is Zer Prime from Visco, and the last is Curare, ceramic primer from Curare, which you can use with your clear fill cements. Last is your cement. It could be a dual cure or a self cure. Dual cure and self cure, we have discussed both these type of cements. So common examples are Relax Ultimate and Multilink from Ivoclar. The Multilink also has a separate primer to prepare the zirconia surface, and Panavia also has a dedicated ceramic primer. If you are using 3M, then the Scotch bond has the MDP. This bond itself has a MDP component to it. You can use it with Relax Ultimate. Now, one more important thing is why we need, once you have done the trial of the zirconia in the patient's mouth, it is contaminated with saliva and blood. So the phosphate from the saliva, the zirconia has an affinity for phosphate group. Okay. So the phosphate from the saliva gets bonded to the oxide of the zirconia. So your phosphate, the oxides are not available to bond to your resin cement. So we need to clean the intaglio surface of the zirconia, so that these oxide areas are again available for us to bond with the MDP molecule which is present in the zirconia primer. So to help us do that, we have zirconia cleaning agents like IvoClean from Ivoclar and Zirclean from Bisco. You can apply these for like 30 to 40 seconds and agitate it and rinse it. So this is a very important step in zirconia bonding. You do the trial, clean the intaglio surface with either IvoClean or Zirclean. Uh, you, studies have shown you can use sodium hypochlorite also, but I'm not sure about it. You can, one more way of effectively cleaning the internal surface of zirconia is putting it in ultrasonic bath for 5 minutes in alcohol, which is time consuming. Then second step, after you have cleaned the intaglio surface, if you have already sandblasted it, you can move ahead to the primer part. Otherwise, you can sandblast it and then you apply a zirconia primer, after dry it, and then you use your respective cement. Usually you use a dual cure resin cement or a self cure resin cement, because the zirconia is opaque enough and it will not let the light pass through it. Okay, I'll leave you all with this few videos where I've shown the sequence for bonding veneers in place and the sequence for using a self-etch cement. Also, I have a video showing the bonding of a fiber post. So as you all can see, the first step is application of hydrofluoric acid. You wash it thoroughly. Then you apply the 37% phosphoric acid for 60 seconds, wash it. Then you apply silane coupling agent. Let it stay for 60 seconds. Meanwhile, you can do the tooth preparation. You can acid etch the teeth. So I'm using a 5th generation bond from Ivoclar itself. So 5th generation bonding agents are good for veneers, but they are not self-cure. So we need to light cure these resin bonding agents for 10 seconds. Then you load the restoration with light cure cement, place it in the mouth and remove the excess. Tack cure it, remove the excess. So as you all can see, I could not pass the floss in between. We'll tackle that. I'm bonding the other side. Tack cure, remove the excess. Yeah, so I'm using a micro cut to remove the cement that has passed through between the two veneers. Since it was only tack cured, it is easy to remove that excess cement. We apply KY jelly everywhere to prevent oxygen inhibition layer, and finally cure it from all surfaces for 40 seconds. Polish the area. So I have luted the two centrals are Emax crowns because they were already prepared. So we had to make thick Emax crowns. So for bonding those Emax crowns in place, to bond those two Emax crowns in place, I have used a Tokuyama ST7, which is a self-etch dual cure cement. So why a dual cure? Because since these are crowns, the transparency was not as much as that of a veneer. So we have to use a cement which is dual cure, not a light cure. This is the sequence for zirconia bonding. Again, for this zirconia bonding, I'm using a self-etch cement from Tokuyama, which is ST7, along with its universal bonding agent. So, as I said, the crown is already sandblasted. After the trial, you clean it with IvoClean. Mix the two bottles in equal amounts. Etchant is usually not required with these type of bonding agents, but since we need to remove the recipe and the debris from the temporary cement, I prefer etching it for 10 seconds. You apply the bonding agent on both the tooth surface as well as the crown and air dry it. That is the most important step, air drying, to remove all the ethanol and hydrogen. No need for curing the bonding agent because it is a touch and cure mechanism. When the cement will come in contact with the adhesive, it both will set together. Remove the tack cure, remove the excess, and then finally light cure. As I mentioned earlier, you try and delay the light cure 5 to 10 minutes after mixing so that there is enough conversion of the cement and it is not hasted by the light cure. This is bonding of a fiber post with the use of a para bond system. As I said, to avoid the incompatibility between the dual cure cements and your bonding agent, we need to stick to the same family. So you select the fiber post, etch it, wash it, apply a silane coupling agent on the fiber post. This helps activate the glass component of the fiber. Air dry it after etching. So this is a conditioner, dentine conditioner of the Parabond system. Apply, agitate, this is a no rinse conditioner. You need not rinse it, so you're not over drying the dentine. Also, you're not leaving it too moist. You mix the dentine bonding agent it comes in 2 bottles. You mix the bottle A and B, apply it inside the pore space, air dry it. Apply the bonding agent on the fiber post, load it with paracord. So this entire system, it creates a monoblock effect. There are no separate links. The bond and the cement and the fiber post, everything becomes a monoblock. So that is why you should stick to the same family rather than mixing the two brands. If you are using another another dentine bonding agent with paracord, then you either mix a dual cure activator with it, or you make sure that those are self-cure bonding agents like the Tokuyama universal one. So it will irrespectively cure itself, and the paracord will cure by its own mechanism. So you need to know the chemistry well before bonding to any tooth substrate. And so yeah, that's about it. These are the contact details in case if anybody would like to contact. And thank you for your time. I hope it made sense.
Yes, thank you, ma'am, for
Yeah,
very vast and informative lecture. I think we can take up the questions.
sure.
Yeah. Uh, there is one question by Dr. Ananya Mehta from
Hmm.
Maharashtra. In which clinical scenarios should total edge still be preferred over universal adhesives?
When you have more of enamel present, or when you need higher dentine bonding strength, in both the scenarios, you can stick to a total edge. If you have more of exposed dentine and it is a vital structure, so you need to be, it is definitely more technique sensitive, but if you are well versed with the technique, then you can go in for a total edge. Otherwise, if you are not sure of your technique, then you can use a self edge or a dual cure. So when
The
it
next,
basically gives a good, when you need good dentine bond strength.
right, ma'am. So the next question is by Dr. Rakesh Iyer from Tamil Nadu. How does dentine moisture affect hybrid layer formation and bond strength?
Okay, so as I mentioned, once you have acid etched the dentine for 15 seconds, which is a recommended time, and you dry the surface. If you over dry the surface, the exposed, what is a hybrid layer? It is basically the penetration of the resin onto the collagen, into the collagen fibrils. Okay, so once you have etched the dentine, dried it, and if you over dry the dentine, these collagen fibrils will collapse, and the primer or the adhesive will not effectively penetrate into the collagen fibrils, and it will give you a less bond strength. If you have not adequately dried the dentine, there is more, there is water present, still you will be diluting the primer, which is hydrophilic, but still, the acidic component, the primer is acidic. It will dilute the acidic component of the primer, and still your bond strength will be affected. So, for your systems like the simplified systems, your fifth generation, where your primer and adhesive are mixed into a single bottle, the moisture level is of utmost importance. Say if you are using fourth and sixth generation, where if you have over dried the dentine, still the separate primer will wet the dentine again, and then a separate hydrophobic layer is applied on top of it. I hope that makes sense.
Yes. Another
Basically,
question.
sorry. So,
No.
basically, the status of your collagen fibrils is what is going to affect the dentine bond strength.
The next question is by Dr. Sandeep Verma from New Delhi. When should we use RMGIC, that is resin modified glass ionomer cement, over resin cement despite lower bond strength?
Yeah, so if you have adequate retention already present in your preparations, you can use a resin modified GIC. Why should you use a resin modified GIC and not your traditional cements like zinc phosphate and polycarboxylate or your GIC? Because of the resin component, it makes it insoluble in the oral environment. So the chances of micro leakage are less. Plus, the GIC, it has some form of covalent bond with your tooth structure. So it gives an additional, retention from the resin side. The main advantage being the insolubility of the cement in the oral environment. You don't get much of bond strength or the retention from the cement if you use a RMGIC. If you need more bond strength or you are relying absolutely on your adhesion for retention of the restoration, so you use a total edge or a self edge and those type resin cements basically.
Right, ma'am. The next question is by Dr. Priyanka Shah from Gujarat. What is the ideal bonding protocol for zirconia restorations in compromised retention cases?
In compromised retention cases, as I mentioned, same, the APC protocol, get it air abraded or you do the air abrasion yourself after doing the zirconia trial. Then you use a zirconia primer, which has the MDP molecule in it. A dedicated zirconia primer or a Scotch Bond Universal from 3M, which has a 10 MDP molecule, and use a dual cure cement. If you have some amount of tooth structure remaining, you can use a self-cure, self-adhesive cements also, but provided it has a MDP molecule. So for bonding zirconia, MDP is the important molecule that you should be looking at. And second is, after you have done the trial, cleaning of the intaglio surface to make it free from the contamination. Like as I said, the phosphate from the saliva, it bonds to the oxide of the zirconia. So to open up those oxide bonds again, you need to remove the salivary contamination and freshen the surface too, so that it can bond with the MDP monomer. The phosphate of the MDP will bond to the oxide of the zirconia.
Right, ma'am. The next question is by Dr. Arvind Nair. Are universal adhesives truly one size fits all, or are substrate specific modifications still required?
Yes, you should modify. As I said, if you are using a universal why it is called as universal is because it can bond to different substrates. You can bond it to emax, you can bond it to zirconia because of MDP, you can bond it to alumina, but still you, according to the clinical scenario, you need to see if you would like to do a selective etch or if you like to do a total etch. In terms of universal bonding agents also, as I said, they can be used in multiple ways. You can do a total etch and paint on the adhesive. If you are using it in a self-etch mode, you need to scrub in the dentine bonding agent onto the tooth surface to etch the dentine. So they can be used in multiple ways according to the clinical scenario. Selective etching of the enamel is important in all the cases, whichever cement you use.
Next question is from Karnataka, Dr. Neha Kulkarni. How does contamination, saliva or blood alter bond durability, and what are the best recovery protocols?
Yes, so as I said, the phosphate from the saliva will bond to the oxide from the zirconia and will occupy the areas, the sites where the MDP would have bonded. So for the MDP to bond to the oxide, we need to remove the salivary contamination. To remove the salivary contamination, either you use a zirconia cleaning agent like Ivoclean or Zirclean from Bisco, or people have recommended using sodium hypochlorite, 5% sodium hypochlorite, but it's not as effective as Ivoclean. Or alternatively, you can place it in an ultrasonic bath in alcohol for 5 minutes. That also will help you clean the, or you can send it back to the lab, or if you have a air abrasion unit present, you can air abrade it again, provided that you know which type of zirconia you're using. If you're using a 5 yttria, you keep a lower pressure. If you're using a 3 yttria, you keep a slightly higher pressure, and then you can do the rest of the protocol, primer and cement.
The next question is by Dr. Rohit Singh about what all factors determine the success of self-adhesive resin cements.
Self-adhesive is a weaker bond. So inherently the preparation should have some retentive capability on its own. If you're relying completely on the self-adhesive, it may have a weak, you have to weigh your options. Say if isolation is an issue, you can stick to a self-adhesive, because if you have isolation issue and you are using a total edge, so again it will be a compromised state. So to keep the protocol simpler, you can use a self-adhesive, but yes, the bond strength would be less with a self-adhesive. So inherent retentive features are important.
The last question is by Dr. Sneha Banerjee from West Bengal. How does immediate dentine sealing influence long-term outcomes?
Yes. So immediate dentine sealing is what, applying a dentine bonding agent immediately after you have prepared the dentine. So according to the hierarchy of bondability, the enamel, the bond strength of enamel versus the bond strength of is more as compared to the bond strength of the dentine. So when you connect the two, you bond the enamel and the dentine together, the shrinkage is going to be more towards the higher bond strength. So you have all complications like post-operative sensitivity and micro leakage and everything. So one is that. Another advantage is, since you are sealing the dentine immediately, again you are sealing all the dentinal tubules. You're incorporating the sneer layer. So that also reduces post-operative sensitivity. And if you decouple with time, you do the IDS, leave it for 5 minutes or for 2, 3 days till the time you get your restoration back from the lab. The dentine bond has matured enough. So it the bond strength in dentine itself, as you move deeper towards the pulp, the bond strength of the dentine decreases. So the IDS will help you increase bond strength in the deeper areas as well as in the superficial areas. So overall, it is a win-win situation.
Ma'am, we have a young budding dentist from Hisar, Dr. Avi Puri.
Yes,
Dr. Avi, you can ask your query direct only.
yes, doc.
Dr. Avi, you are not audible.
Sir,
Yes, now you are audible. Yes, please.
you can say that the bonding agents
Uh, Sorry,
Okay,
doc,
I think he's traveling. So,
yeah,
okay, I'll read out on your
sure,
behalf
sure.
that in clinical use, you said to use sixth and eighth generation, but
Yes, yes.
fourth generation is gold standard one and seventh one is all in one. So we have to use all these in clinical use, like your take, he's asking.
So as a clinician, I would not like to increase the inventory. I would like to stick to a few products that are applicable to the various clinical scenarios. So depending on those, I believe in sixth generation because one is they have MDP. the Clearfill SE 6th generation bond has MDP in it, so it can be used with various substrates as well as in various clinical scenarios in deep dentine, in post operative sensitivity cases where you need and it has a relatively good bond strength as well. Plus, you are not relying on the drying of the dentine on the operator skill. Say if I use a etchant, as in case of a 4th generation, and I over dry, so still I'm not achieving the adequate bond strength. Or if I don't dry it adequately, so still it is a compromise. So 6th generation, it makes it relatively easier because you are not using an acid, you're using a milder acid from the primer to etch the dentine, and if for your enamel you can do a selective etch. So overall it is a plus. Clearfill SE is again a gold standard for a lot of, it is considered as a gold standard for bonding. And 8th generation, again, for your routine clinical scenarios like class 2s, class 1s, and for your immediate dentine sealing, in lot of, or to bond to your zirconia, again, it has an 10 MDP present. You can use it in multiple ways. You can use it as a self-etch variant where you don't use any acid. You can do a selective etch on the enamel and scrub the 8th generation into the dentine to etch the dentine, or you want to entirely do it as a self etch. You can scrub it everywhere and it will act as a mild acid. So there are multiple ways that you can use that 8th generation universal bond as. So these mainly you can cover all the clinical scenarios with this. Also, the 4th generation, it is there are not many products which are available in the market. Being a gold standard, OptiBond FL hai, but in Indian markets that is not routinely available. So yeah, 7th generation, I don't prefer a 7th generation because it puts everything in together like a hydrophilic molecule plus a hydrophobic molecule. So again, it is not compatible with many cements, but still you can use it for your routine class 1, class 2 restorations. So to keep the inventory short, 8th universal bonding agent and a 6th generation should do well.
Thank you, ma'am. Now I request Dr. Rinku ma'am to please deliver the vote of thanks. Thank you so much, ma'am. It was very much elaborate and a lot of queries also came.
Thank you.
Yeah, over to you.
Thanks a lot, ma'am, Dr. Deepika, for sharing these wonderful insights and telling us about the bonding protocols in so much detail. And we are very thankful that you spared your Sunday afternoon. And hope
Thank
so
you.
we'll meet
My pleasure.
someday in person also.
Definitely. My pleasure.
Okay, thank you, ma'am. Thank you once again.
Thank
On
you.
the
I
behalf
hope
of
I
all
did
IDU
justice.
Hisar. Yeah, it was great. It
Okay.
was a very great lecture. Okay, thank you, ma'am.
Thank you. Thanks a lot.
Over to you, Asya. Asya.
Yes, sir. Am I audible?
Yeah, you are audible.
I thank all the delegates for this wonderful and engaging lecture today. And it was a really a pleasure to have you here, ma'am and sir, with us. So, with this, we conclude the session here for today. Thank you and have a great time ahead, sir. It was a pleasure to have you all here.
Thank you.
Thank you.
Thank you so much.
Thank you,
Thank you so
everyone.
much, everyone, for
Thank you,
attending.
everyone.
Bye-bye.
Bye.